Today we have Alfonso here with us. Do you want to introduce yourself before we get into this? I think a lot of people may already know who you are, but it's nice to get a name and a face.
Sure. Yeah, my name's Alfonso Pineyro. I am a prosthodontist here in the Seattle, Washington area, and I've been here for, man, like a long time, it feels like, but what is it, 18 years?
Me too.
So,
I've been in practice about 18 years
yeah,
now,
yeah.
essentially. After
I mean, I
residency,
think
I would say.
we started in this area just around the same time.
Yeah.
So,
Yeah,
yeah.
I'm also in Seattle. Well, my practices are north of Seattle, but I do live in Seattle. And so been here the whole time, since my residency ended basically. And we're going to talk today, we're going to get into some of this full arch stuff. There's so much out there. If anyone's on any sort of social media, you've seen all these things, the Patsy protocol, all these zygos, pterygoids, everything like that in between. And, it's hard to almost decipher like what's the proper way, what works, what doesn't work, what fails the most. And Dr. Pinero, or Alfonso, I should say, he's done a ton of these cases. Like he's worked them up, he's treatment planned them, he's restored them, he's dealt with people's failures, his own, like it's everything, everything in between. And so hopefully we're going to get into the weeds a little bit more about this stuff because I think there's just so much information, and with that becomes so much misinformation. And experience helps. We've failed at things, and I've definitely failed at things, and you learn from that too. So that's all good. But I was going to ask you, so you are a prosthodontist. So before all that, like you were in high school, college, like why dental school for you? I like to
Well,
ask people this because
yeah,
I
yeah.
know my path and it was weird, and I just want to know how other people did it.
Well, my dad's a dentist,
Okay.
so I kind of grew up with it, and I'd go into his office, and he had a little lab, and he'd have, waxing stuff up and waxing up dentures, and as a kid and an adolescent, you're like, this isn't for me. I don't want to do what my dad does, right? And then I kind of fell into it over time. I mean, I think your brain matures over time. You're like, actually, this is a good profession, and my dad loves he loves what he does. In fact, he just retired
Whoa.
in March, 85 years old.
Yeah. That's a long time.
I surprised him on his last day of his office. I flew in because I was doing a lecture in New Jersey, and they're in upstate New York. So his last day was on a Thursday. I did the lecture on Wednesday, and I drove up, and I snuck in the back door. They opened at 9 a.m. I snuck in the back door. I put a little smock on, and I told the assistant, get out of the way, get out of the way. And I came in he was, talking to the patient. He couldn't see me. And I just said, you have a new assistant for today, for your last day. And he's like, what are you doing here? Because, he thought I was in Seattle, but I was
Hmm.
there. And I assisted him all day. And then I arranged like a little party, like a surprise party at a restaurant. And he's in a small town in upstate New York. There's
Yeah.
about 2,500 people in the town. Everybody knows him as the dentist. And one of the ladies that I did assist him all day too. One of the ladies that, yeah, I'm a terrible assistant.
Yeah, me too. I can't. I don't even know how to do
Right.
that.
But one of the ladies, she's like 65. He's been in that practice for 50 years. She's like, I've never had another dentist but your dad. I don't know what I'm going to do.
Wow.
And I saw him give, an injection, and his hand is so steady, just goes in and pulls it out. I'm like, what are you retiring for? You got 20 years in you
He's got
left.
that
I
muscle
mean,
memory down.
yeah, I'm like, wow, this
I
is,
can't even do that. I'm like,
I know, right? Some days I'm like, I had a
yeah,
little
I
too
know.
much coffee
A little
today.
too
He
much
goes in like,
lotus there. I don't know.
yeah. And then at the little party, he kind of got emotional, and we don't know how to deal with emotions in my
Yeah.
family. So
Right.
he deals with it with humor, and he says, "Come here, I want to tell you something. After 50 years, you're the worst assistant I've ever had." So that
Probably
was
true.
his little.
Probably true. That is pretty
It's
funny
probably
though.
true.
That's awesome. So he's like chilling now, hopefully.
Yeah. So no, well now he goes to the grocery store. He still has the keys to the office. He didn't sell it or anything. He just shut it down.
Oh, okay.
He sees one of his former patients, and they're like, "Hey, Doc, I got this thing." And he's like, "Let's go. I got the keys." And he takes him in. So I call
Man,
my mom, and I'm like, "Where's Dad?" She's like, "Well, he's been at the grocery store for 3 hours. What do you think he's doing?" I'm like, "Yeah,
man.
can't give it up."
As long as it's not like Breaking Bad where he's like, yeah, I'll be gone for a while. But yeah, that's awesome that he's still just, it'll that'll phase out, I'm sure. Like once he realizes like, hey, I can not do that and
Right.
just relax a little bit more.
Yeah.
That'll be cool. But that's awesome. So yeah, so dental family, that makes sense. None of my family were dentists. I just,
Yeah.
decided way back when. And so you were in college, and then like so you were taking the DATs and then doing all that stuff. Where'd you go
Yeah.
to school? Like what area were you in? Were you in New York then?
I grew up in New York, and then my sister we were at SUNY Albany. We were both there together, and she's a year older than me, and she wanted to do medical school, and she wanted to do medical school in Guadalajara, Mexico, because they had a U.S. dental school. So my dad's like, she can't go alone. She wants to do this. Go down with her, but you have to take classes. So I went to the dental school and I got accepted. And at first I'm like, I'm going to be here for like a semester and then I'm going to go back and do my stuff over there. But I loved it and it was a great experience. And I was there for 4 years. And the difference in the underserved population is very big,
I
Mexico
can't even
compared to US.
imagine.
So
You must have no problem with
started
getting
we
patients. Like it's
started doing
crazy.
procedures after the first 6 months. They'd take us into underserved areas and they'd teach you how to anesthetize on the spot. Go
Right.
in and you do like, and it's like, oh my God. So we had a lot of clinical experience, because we started a lot earlier. And then I moved back to the States and I did a 2-year AGD program at the University of Rochester. And that gives you your U.S. dental license. And while I was doing that, the PROS program was upstairs from the AGD program, and my buddies were there, and we'd play soccer every night after we were done with patients, and then those guys would go back to the lab, and they were there till like midnight, 1 a.m. doing lab work, and for some reason, I enjoyed that. I enjoyed
I was
being in
like,
that.
that's your calling, man. That's hard for
Yeah,
me to do, but that's awesome.
and they were doing things that I didn't understand, like they're restoring a cancer patient and they're communicating with the plastic surgeon, the oral surgeon, the orthodontist. I mean, they're doing all of this multidisciplinary treatment. And I'm like, I have no idea how to do this. I don't even know where to begin. I wanted to know. So after that, I applied to PROS. I got in, and the rest is history.
And did you go to Prost there then?
Yeah, in Rochester.
Nice. How big was the program? Is it like one or two, something like that, or three,
We
four?
had, at that time, it was two per
Yeah.
year.
Yeah,
Yep,
ours
it was
program
two
was
per
two a
year.
year for my
Yeah.
residency too. But yeah, that's nice, man. So you got there and then you decided, hey, I'm gonna take this to Seattle, take my talents to Puget Sound.
Well, yeah, when I was there, I met a girl who was from Seattle, so I followed her, and because I was going to be in Manhattan, I had an opportunity to be in the city, and
Yeah.
I moved out here for the summer. I said, I'm going to take some time off after my residency. We've been in school for a long time. I want to take off like 3 months and not do anything. And they sold me Seattle. It didn't rain one day, and we went to Vancouver and we went to Portland and the San Juan Islands and Mount Rainier and Lake Chelan. I'm like,
We
it's
did everything.
beautiful out here.
Yeah.
Yeah. And then I moved back. So I went back and then I said, I'm moving out there for good. And I moved back in January and then it rained every day for 6 months.
Yeah, that's the fall winter here. It's great. Yeah. I feel like it's like 8 months, but yeah.
But it's fine.
Yeah, you got to get out of town during those times as much as you can. I think that's the way you got to do it. But so yeah, so you've been in pros just as long as I've been in private practice with surgery. I think I saw you a long time ago now. You guys were doing lectures on, cement extrusion on restorations, on implant restorations, right? You probably did 1,000 of those, I think.
Yeah. I mean, yeah, that was 2000. I think our first lecture, I think you were at our first like official lecture.
Before you
And it
guys took
was
off, like the trajectory, I feel like you guys were
right.
doing that in so many places. Like I'd look
Right.
up.
Well, we had a room. The first one we did, I think, was we had a room full of oral surgeons. You were there, and it was just the oral surgeons from the Seattle area, and we started talking about the cement complications. And at that time, nobody was really thinking about the
Yeah,
problems,
right,
right? The
right.
after effects of doing poor restorative treatment on implants, because we were thinking about the microgap and this, that's what we were focused on. It's like, well, this cement is causing problems. So then after that, we started to expose that, talk about that, do some studies, do some research. And I think people have changed, doing dentistry that way.
I can imagine even just when I don't use a lot of cement. The only cement I ever use is Tempond now because you pop a crown off next door to a tooth and you're like, oh, I got some Tempond, and I'm like mixing it up and putting in there. Even just a
Yep.
little bit of Tempond, I'm putting that crown on, and this is me as an oral surgeon. It all like a lot of it comes out the sides, and I'm like trying to get rid of it, and it's like not easy. I'm like, how do you guys do that? Like, I have no idea. That's what happens. People leave cement there, like not even Tempon, but the real stuff, and that does cause problems. I get that. I'm like, even for me, cleaning that was tough.
Yeah.
So
Yeah.
yeah.
Well,
So oh, good.
yeah, I mean, that was the issue because, we try to do things the same we did with teeth. And I mean, the biology is different, the tissue attachment's different, the way the cement flows is different. So all of those things were not really considered. We're like, we're dentists. We're going to make a little post that looks like a tooth prep and we'll put a cement in it, we'll put it in, and that's it.
Yeah. I mean, it's crazy how that goes. And then you went from, I assume in your practice, you were doing a lot of full arch. You were probably getting into that. I know a long time ago, we did a case together. At the time, yeah, I think it was an uppercase. We did it flapless or something. And that, because it was, I don't know, everything was just flapless, just punches, got the implants up there, integrated, and so forth. Since then, though, things have changed a lot. Like,
Yeah.
parts and pieces are different. Obviously, that always changes. Protocols, like all these things you're hearing about, like Patsy and all these other things. I know you do a lot of full arch restorations in your private in your world. Do you have any thoughts on that? Like, how's it gone in the last 10 years? Good,
Yeah,
bad,
I think
ugly?
that case that we did was 2013, 2014.
Yeah,
So over 10 years. And right, today we would do that case very differently, right? We would flap it, we would recontour the tissue, I mean, he was a dentist, so there wasn't a lot of bone reduction that was needed anyway, but we would have done things a little bit differently. But that's the thing that has enticed a lot of dentists to get into full arch is we got lucky with that patient because that patient, I can tell you, is still walking around with the same teeth. The implants are still healthy. And we got lucky because he is biologically superior to most patients, and he can get away with some of our errors, right? Some of our poor planning in that case, right? But he's still walking around with the teeth, same teeth that we made. I like to follow those long-term cases because you learn from that, right? You learn from those cases that we did, and you see a trajectory of what you see from patients. And one of the things that back then, and still a lot of people follow now, is the maintenance piece, right? Because the ACP came out with a consensus paper, and they said, well, you don't have to see these patients. You don't have to take out the teeth. You can leave the teeth in place. Only if you have a mechanical issue do you have to remove the prosthesis. And, as a prosthodontist, I can tell you that the ACP is wrong on that. They're completely wrong. This is not what you're supposed to
is
do.
that what they're still recommending
It's
at this point? They
still
haven't changed their
recommended.
position.
They have not changed their position. No, they haven't changed their position. And the ACP is a great association. But the position that they have was the same position they had almost 10 years ago. It hasn't changed, and they just wrote an update to that just a few years ago. And it's like, well, how many full arch restorations are the authors of these papers actually doing, right? Because unfortunately, the ACP, is made up of great prosthodontists, but they're in academia. A lot of them are not in private practice, and I think that's that's a disadvantage. And it's not the right information that we should be sending to the providers and to patients. And we're just going to put it on, and then we can see you every once in a while, clean around it, but we don't have to take it off. And the reason for that is because that kind of mentality goes back to immediate dentures, right? Immediate denture patients or denture patients, once their dentures are comfortable, on average, those patients don't return to see a dentist for 10 years.
Yeah.
So that
That's true. I
immediate
ask
denture
people like in my
mentality.
office, when they come in with
Yeah,
issues, I'm like, how long have you had that denture? Years. When's the last time you had adjusted? 10 years ago. That's pretty common.
exactly.
I'm like,
I
you
mean, but
probably need to get that
that's
redone or adjusted, you
yeah,
know?
that's published knowledge. It's a 10-year average for patients to come back. And the other thing was the concern about the screws, right? Well, then what do you do with the screws? What if you lose a screw? Well, you have to replace a screw and there's a cost involved. And then if you tighten the screw, it'll lose torque value. It'll have deformation. It can break. And there's published papers that say you can torque and retorque a screw up to 10 times with no deformation. And that's sort of hard for people to grasp, right?
Yeah.
And they want to change the screws and but you don't have to. In
Is
many of these
that
cases, you don't have to.
is that screw study, is that for crowns and bridges, or is it specifically for like multi-units, or does it matter? Because I just know
That one
you're
is for
torquing a
crown
little
and
higher on
bridges.
the, or what are the multis? It depends on what system you're using. It just depends sometimes what your torque value is.
So yeah, so in that study, they looked at all different systems, all different screws, and they were able to find that 10 times but a screw is a screw, in
Yeah.
my opinion.
Yeah.
If you have for a crown, that crown is going to take a lot more force than the full arch that has
Cross
the
arch.
distribution of
Yeah.
forces throughout the different number of implants, right? So we've been doing hygiene on patients. We take the teeth off, we replace the screws, we look at the screw. If we see some debris on the screw, if we see the screw has been deformed, if you can't hold the driver on the screw and turn it upside down, it comes off, that screw's gone, right?
Okay.
We're not going to use that screw. So we look at different things, but for the most part, we're reusing those screws a number of times, and we don't run into, oh my gosh, the screw broke, the
I
prosthesis
think that's what
loosened up.
people
That's not an
fear,
issue.
right? They do that and then they might break a screw or something and now they're stuck. I feel like that's a big fear for people.
And that,
So I
and
assume you code for this, right? There's a code to do this maintenance. Like you can't do it for free because it's a
there is a
procedure.
code. Yeah,
Yeah.
there is a code for that. And off the top of my head, now you put me on the
No,
spot
no, no,
because I
that's
don't.
fine.
We don't take insurance at this point, but
Yeah.
they can be reimbursed through that.
Sure.
The thing that with the screws now, those screws that we've been using for 20 years on this type of restoration are different. Some screws now are coming with the angled screw channel, and that's fine. Now those screws you might have to replace because you're torquing those at an off angle, and then you can strip the head of the screw. Now if you strip the head of the screw and you have a big zirconia prosthesis, and now you're trying to get that screw out, you're going to have to cut a big portion of that zirconia prosthesis away to get a straight reverse thread driver to get that screw out. That's going to be a challenge. So I don't really try to use those types of screws
Right.
because I try to make sure that we're communicating with the surgeon. We want the implants to be a certain angulation where those screws can be problematic. But it works because we're being taught that you don't have to remove the teeth. Now, what I've seen is, we have great long-term success, but the great long-term success comes from those patients that come back for maintenance every year.
Okay.
And then we see those patients that disappear for 7, 8, 9 years, and they come back and you're like, well, you got a bunch of calculus here and you have bone loss around this implant. And, you never came back for maintenance. And that's a big part of it. And we're still resistant to that.
This is I don't think there's been a lot on this topic or this subject. So here's the thing. So I don't really watch these shows, but I've seen commercials and previews for these shows. Like those shows for like that one doctor in Texas, I don't know where he is, but he does all those bariatric surgeries. Like the really heavy people, like 600, 800 pound people. Like it's a reality show, right? Or like you've seen that? Where they
Yeah,
come
yeah.
in and then he talks to them and he's like, you got to do some dieting on your own first before we do the surgery to prove that you can do this afterwards. And people have to go through this, right? You have to do this before they qualify you for that bariatric procedure. what we, and I'm relating to what we do, is like a lot of these full arch patients, I wouldn't say a lot of them, but a fair amount of them, they have had bad habits. I mean, there's a reason for this tooth loss, periodontal disease, and so forth, right? And so I don't think we do that kind of a job with them in general. I'm saying we, but the profession, like to teach them, hey, this is how you brush. This is what you got to do. Even when you have a prosthetic, you have to clean it every day. You have to get food from under it. These are the things you have to do, or you're going to get inflammation around your prosthetics, like you would around your teeth. And so I think there's a fair amount of people that, oh, I got my teeth out. I got this thing in. I don't really need to do much more now. And meanwhile, underneath, you still got to do some hygiene yourself. Does that make sense?
Yeah, that's the absolute truth. And one way to combat the patients returning is giving them a warranty on the teeth and on the work, because if you come back every year, you get this warranty. If you don't, you're out of warranty.
So how does that work? So what you guys do basically is to say, hey, you got to come back every year, and that means, if something happens, you're going to get some prorated procedure fee or something like that, right?
Yeah, I mean, it's sort of my goal is when we're doing these treatments is to make sure that this is a long-term success for the patients, or else why the hell did we go through all this effort and time and the patient's money? We're going to do something. And that's what I tell patients. I need your commitment, and I need your commitment that you're going to come back and that we're going to check you every year. And you might be a patient that needs to come back more than once a year. It might be 2 or 4 times a year. It just depends on your biologic makeup, your production of calculus. And some patients come in, serving, I'm sure you've seen these patients that come in and they've been gumming it for 10 years, and you don't know what kind of calculus production they can produce, right? There's no way of knowing that. And then you put something in their mouth and you're like, wow, that built up in a week.
Yeah.
That's amazing,
Yeah, they
right?
probably didn't brush their gums forever. And then like now they have
Right,
something in there, like,
right.
they don't really,
And
yeah.
and the problem is that, you know, they have to understand that we kind of customize the maintenance for these patients because of that,
Yeah.
you know.
That makes sense.
Like the patient that we saw, 10, 12 years ago, he could come in every year. He's got the right tissue phenotype. He's got,
Good
you
physiology.
know, low calculus. He's just made to take implants. We don't understand enough about it yet, unfortunately. But
Yeah. That's the
other
hard thing. Patient
patients,
selection sometimes is
yeah.
challenging.
And how do you pick those patients, right? How do you pinpoint those patients?
Experience helps. Just, watching things fail in some people that you think, that torqued high or had a good ISQ reading. You're like, I don't know what happened. There is a thing about physiology and biotypes and all that stuff that does play a role. So like here, you talked about broken screws earlier. Do you have a trick for getting out broken screws? Like not so much even full arch, but in any crowns, bridges, like those are some of my worst consults. Like, oh, the dentist broke the screw. I'm like, oh man, I'll try. Do you have any tricks? Like, what do you do?
Well, there's a lot of challenges with screws, right?
Yeah,
And
yeah. I'm trying to learn something
the
here,
thing
actually.
that you have, what's that?
I'm trying to learn something here.
Yeah, no. Well, it depends on the system too, right?
Yeah,
Because
true.
the system, every system has a different screw. Every system has a different attachment, the way the abutment's attached. But the good thing is, if the screw's broken, if the head of the screw is broken, or then that's an easier removal than if you've stripped the head of the screw.
Okay.
Because if you strip the head of the screw, it's still torqued, it's still stretched,
True.
right? And now you have to get enough force to remove that torque, to detorque it. If the head of the screws come off, then you just need enough force to move that screw around with a pointed object, and that's our first. Um, that's our first option is a very sharp Explorer or a sharp Montana Jack, something that has a very sharp edge. If you can kind of go in a counterclockwise rotation, you can kind of dig into the titanium a little bit and eventually get that thing out. If that's not working, then a number of things can happen because the amount of time the screw's been broken and a restoration's been off also influences, because you can get calculus buildup in the threads too.
Man.
right? And now try to remove that. Now you need a lot more force. So the other thing we do is, and this is kind of dangerous, so you got to use a really hot instrument,
Okay.
and you take that hot instrument and you have to get it into the threads and touch the head of the screw and leave it there so that it loosens up that calculus or debris,
Okay.
and then you start rotating it. And you might have to do that a few times, right?
Interesting.
And if that doesn't work, then it's it's mechanical. They sell the reverse torque drivers that you kind of have to go in. And every system has like a little pilot drill that you can get in there. And those work okay. But at my last step is a slot and a slotted screwdriver that if all else fails, that usually works for me.
And you're using just loops with that? Okay. Yeah, I've tried everything. My screw removal rate on random broken screws is probably like 45%. Like it's less than 50. But
Yeah,
it's not
yeah.
easy. I'm like sometimes like you need to see a prosthodontist. You know, maybe they have a trick. You know, it's like
Well, yeah. I mean, it's they don't always work for me either, but
yeah,
I sometimes I have the patients come back and we try again because eventually we can figure out a way of doing it. And but warming up, heating up the screw really is that's when you feel okay, I can see something move now, because
interesting. I've
before,
never
if
even
it's
thought
not.
about that. I mean, I've tried like the back of a wooden Q-tip. You put the wood on it and push it in and try to get that to engage. But if it's torqued in, I don't think that's going to be enough either.
The back of the Q-tip works well once that screw is moved a little bit,
Okay. Yeah.
but you got to get it to move a little bit. Now you know that that wooden screw is going to work, or that wooden tip is going to work, but you got to get it to move a little bit.
Yeah. Interesting. I've been performing full arch dental implant surgery since 2012. I started back then with Nobel implants and I continue to use them today. Getting consistent results over time and seeing these restorations in function over that length of time has basically strengthened my use of the product. You know, there's over 100 implant systems out there. I just choose the one that's been the most consistent for me. Yeah, so back to the full arch stuff. So like you've seen it all. So what do you think about the Patsy and all that? Does it all make sense? Is that the way to do it, or is there other ways to do it? And the protocols, things like that. For you need to look at your anchorage. You need, if you don't have this, you need to go pterygoid. If you don't have this, you need to go zygo. Like, what's your thoughts on all that?
So I think we've gone. We're now at a point where a lot of people are doing full arch. Um, it's fine. I think if you're getting the proper training and you're comfortable with surgical procedures. I mean, I don't do surgery still. I work with oral surgeons because I'm not equipped to deal with the complications, right? And you are. So I'd rather work with you, and we're going to do this because some of these get hairy, and there's no way I want to be stuck in that. But if you learn how to deal with the complications and you feel comfortable with the surgery, you want to do this, that's fine. I've seen a lot of pterygoids. I've seen a lot of zygomas, and I don't always think they're necessary. I don't always think they're necessary. And they're beautiful on a Instagram post.
Yeah, I know
You
that's the
know,
thing. They're all over the place, right?
it's a beautiful picture. But if you have enough bone in the maxilla for 4 to 6 implants, and even if you're going to have a cantilever, that's fine. I mean, I strongly believe that that should be our first step, right? Because we're now seeing good long-term results from 10, 15, going up to 20 years. But what happens after that? And now you have maybe a cluster failure of implants, or the patient's biology changes, or they're on different medication. And now you have a zygoma in there, or 2 zygomas and a pterygoid, and those fail. And now you've destroyed that bone. You've got no other shot now, right? So I think zygomas and pterygoids in young patients would be something that I would kind of hold off on, because that's my backup plan, right? That's my backup plan for 20,
Your
30,
last resort, basically.
right. And unfortunately, a lot of these patients are getting younger and younger. They're drugs and, lifestyle. And you're seeing patients that 20 years ago, they're an immediate denture patient, right? All the teeth are decayed down to the gum line. 20 years ago, that's an immediate denture. Today, you can do a full arch. But I would reserve some areas of bone for the future. And sometimes we place extra implants and bury them.
Yeah, I put sleepers in.
Yeah. On young patients, I feel very comfortable doing that. I'm going to put a couple more implants in you. We're not going to use them, but they're going to be there. You know, it helps me sleep better at night. Is it going to work? We have no idea, right? There's no way to know, but you sleep better at night doing that.
Yeah, we just call them sleepers. I just tell, I work with Kyle Schmidt a lot in a lot of cases in the past, and other people. I'm gonna put a couple sleepers or put a sleeper here, for whatever reason. But yeah, like the pterygoids have been, people doing those way in the back, and sometimes I see these restorations. There's like 4 or 5 in the front, and then they got 2 pterygoids. And then I'm wondering, do you really need the pterygoids at that point? I don't know.
Yeah, I mean, my protocol is ideally we're getting teeth in the patient the same day. Now, if we didn't have great torque on those anterior implants, I might say, hey, let's put a pterygoid in so that patient can leave with teeth that day. And that's a good option for patients, right? Because it's going to be much more comfortable healing and transition from whatever they were at to their new teeth. And that's a case where I would say pterygoids are okay, right? And luckily for younger patients, the bone density is still good. We still have good, torque on a lot of these. But for older patients, postmenopausal women, those patients will put in a couple of extras to get better torque so that all of the implants have a better chance of survival during the temporary phase.
Yeah, what are some trends that you've seen in these, like besides the pterygoids, I guess the zygomatic implant trends and so forth? I call them trends, but just because what's the arc of the social media has been. Is there anything else that sticks out to you? Or in another way, maybe like what are the failures you've seen the most? Like what happens? Is it upper jaw, lower jaw? Does it matter? Is it like too narrow of an implant in the front? Like don't use the 3.5s, you got to use this, things like that. Any
Yeah,
tips?
I don't have any, I haven't seen any correlation between the width of the implant and increased failures. I think the the width of the bone has to dictate that, right? If you have a patient with thinner bone, you have to use a thinner implant. And if you have enough bone around that implant, this can be a successful treatment. So I'm not really seeing any correlation there. But those patients that where you can see some issues, and a lot of the failures are not implant failures. They're prosthetic failures, right? And they're failures of identifying patients, right? And identifying a patient's ability to adapt to change.
Yeah, I got a really good example of that. There's a case I've been working on for a little while now, and before all this started, I think the patient had a couple implants, ended up failing, heavy bruxer, heavy grinder, like a lot. Like he's broken crowns, bridges, things like that in the past. Now that he's a full arch patient, since then he's broken his restoration, his full arch interim multiple times. Same reason. And he's had a couple more implants fail on the upper right full arch, had to replace those, graft and come back basically. So this is a long-standing pattern of just, parafunction. And most recently, he then fractured the lower left angled implant, the number 20 area, fractured almost to the tip of the implant, which I have rarely seen it fracture that way. Like, it's angled like this, but it's the lower third of that implant that broke off. And I had to go retrieve that little lower third, graft it. We're going to come back and replace it. But that's, again, it's high parafunction. There's a lot of stuff going on there. It's difficult.
Yeah, the parafunction is something that you want to try to identify. And what I've seen is, the patients that we were mentioning earlier, the patients that have not worn anything for 10 years, and then they decide, hey, I want to come in and have teeth, they have a hard time adapting. They've been used to having all of this room in their tongue. Their tongue is completely displaced. And now you try to go and put teeth in. I mean, they had a hard time wearing dentures. That's why they probably had dentures at some point. They never wore them. Now this is fixed in place. Now, two things happen. One good thing is that they can't take it out, so they need to work on getting used to it. But you also have to be willing to make a lot of modifications to the teeth, because they're going to tell you what feels comfortable and what doesn't, and what they can adapt to and what they can't adapt to. those are the challenging ones, right? Because you're like, well, we're going to do this. The patients that come in with, VME, and you're going to close the video, those patients adapt really easily, right? They adapt easily because you're changing, you're making more room in their mouth. You're closing the VDO, but now they have so much more room for their tongue and their cheeks. Those patients always adapt nicely. But when you're changing, a patient that's a class 2 and they want to be more class 1, and you're pulling the lower teeth out a little bit, bring the upper teeth in a little bit, those patients have a hard time adapting too. From a speech perspective, from a functional perspective, and you really have to work with them and tell them all this ahead of time.
Yeah,
You
that's
know,
the key. Because they're going to go,
we're
I'm
gonna
just keep biting my tongue. Your teeth aren't right, blah, blah, blah. I'm like,
yes,
honestly, I mean, you didn't have teeth there for like 10 years.
right. This isn't my bite. I'm like, well, this is
I mean, your maxilla mandible is, the relationship is quite different than it was, 25 years ago
yeah,
in general without teeth. But yeah.
yeah.
So yeah,
Well, they've never
it's all in the pre-planning and in the patient the selection. Are there patients that you say, like, you look at their medical history and things, and you look at, the case, and they may have enough bone for something to work, but you just know in your own mind that it's not going to work out well, and you just say, sorry, you're not a good candidate? Like, are there people like that, or you try to get everyone in, and like, we'll do
No, I mean, we
zygos,
have
we'll do
to.
this, we'll do that? I mean, are there cases that you just say, knowing what you know now, that you would just say, you know what, I don't think this is going to be a good solution for you?
Yeah, I mean, we've had to reject a number of patients, and from, poor medical history. I mean, if you're going to sedate these patients, they're high risk, right? Of all kinds of problems. Patients that have had head and neck radiation. I mean, trying to do cases on these patients, it's a lot for these patients, right? If you even want to attempt to do this, there's, dives, and it's a lot. So a lot of patients, you tell them this is what you're going to need, and still we might have a very small window of success, you know. And they get it and they opt, well, let's look at other options, right? But we also have patients that come in and you see the scan and they're like, I want all my teeth out and I want implants. And you're like, no, your teeth are beautiful. I can't do that. I've had a lady that came in and she swore at me, like screaming, you effing broke my dreams. You crushed my dreams. And she walked out in the waiting room and she started swearing at everybody in the waiting room and left because I told her she had beautiful teeth. She just
Something in her
wanted,
head that it's a
well,
better way, and yeah,
yeah,
didn't make
yeah,
sense.
it's,
But that's the
it's the,
patient you don't want either, because if they're going to do that, imagine if there's a problem later, like how they're going to act, and it's
well,
tough.
yeah, it's just unrealistic expectations, and they want a pretty smile, and they don't think their smile is pretty. And with a couple of maybe, veneer here, maybe a little bleaching, you're done, and you'll be very happy.
I mean, going
They just
from
can't see it.
a full arch to from full teeth to a full arch is a big deal. It's not a lateral move in a lot of cases. Like, there's going to be compromises there, obviously, so that's the thing. I had a patient once, and this was when I was in dental school. I went to Tufts for dental school, and in my third year, I did an externship at a prison in New Hampshire, and level, state pen. And when the inmates went into the dental clinic, like, they were super happy because this is like their first time. There's like women in there. There's music playing. They didn't want to leave. Like, I had one guy that came in just for Paradex rinses. Like, he would switch that Paradex for 15, 20 minutes, and you had to tell him, okay, that's enough. You got to go back to, the general population or wherever. He was just like laughing, just like the whole time. I had one patient there that is like, I want all my teeth out. I'm like, no, he's actually had really good teeth. I'm like, he's like, no, I need them out. And he was there for life, but he wanted it for a different reason. But I'm just saying, like, it's a
I don't want
little
to know.
different when you have to tell someone no.
Yeah, right.
But that's a story that I always like randomly remember somehow.
That's a great story.
That's a good story. I'm like, dude, no, you're not taking your teeth out. I know you're here for life, but no, that's not how it
Yeah,
works.
right.
But yeah, like that happens. Patient expectations. Is most of your practice in fixed, or do you still have a room for like people that want like locators or conus or something removable even off of implants, or is it pretty much you want to just do fixed restorations?
No, we do. I do a lot of dentures. Patients that come in and they have a lower, we do a lower arch opposing an upper denture. I mean, some patients just have no maxilla, they have no zygo. There's no option. But the mandible's great. So we do a lot of dentures opposing that. I do some, here and there I do over dentures. The challenge is that for those patients, you really have to lower the expectations because a fixed restoration is going to be completely different than a removable restoration. And those patients, you have to be very honest with them and say, hey, this is going to happen. You're going to have to take the teeth out here. You're going to have to do this. And because a lot of times they'll come back and be like, well, this isn't what I expected. And it's like, yeah, well, this is the best we can do with this type of treatment.
I find with the uppers in particular, like once you tell them, if you have we can do it off of, 4 more implants on the top, and then you can have something removable. As soon as you tell them, you're still going to probably have your palate covered. A lot of them are like, oh no, yeah, I don't want that. Like, yeah, that's their like thing that they don't want. And like, they're like, all right, you're going to go fix then. That's fine. But that's a big deal. Yeah, that would be a big deal for me. I don't think I could ever do that without something permanent in there for myself. So what about failures? Like we briefly talked about them before we end this. I'm just curious, like, do you see it have you seen zygos fail? You've seen pterygoids fail? Obviously any other implant in any of their sites. Are there any trends that you see like with that, or like people maybe doing them differently than you guys do them and you kind of have to, fix them? Like what have you seen? Like anything in particular?
Well, I think more than, like I said, more than implant failures and these, because that happens to anybody. Implant failure can happen to anybody. And what I see is, again, the prosthesis. And the prosthesis, we've gone to zirconia. And zirconia is a great material. To be honest, I don't find it as aesthetic as good denture tooth and pink acrylic. I think the translucency in that, it's much more aesthetic. It's much more lifelike. But doing zirconia, we can do everything digitally.
Right.
And now we've changed, a lot of people are going towards doing the zirconia direct to the multi-unit abutment and screwing it into that. And that's something that is becoming very popular. And it's popular because it's an easy workflow. You don't have to have a model. You can just do all of this digitally.
Are you doing
But I
like
think
photogrammetry then or something like that?
well, you can do it with photogrammetry. You can do it, yes, you can do it with a number of different ways. You can do it with a scanned model. If you have a model, you can scan the model. You can do photogrammetry. You can do scan bodies with a iOS. There's a lot of different ways of doing it, but the workflow is, because putting those titanium copings in is an extra step. It's an extra lab step, and a lot of offices are now milling in-house. They have their in-house mills, and they don't want to have to do that. And that's a trend I've been seeing. And I think it's it's kind of unproven at this point. There's not any research on it that I've seen about long term, because you're using a titanium screw into the zirconia. We know that titanium, or zirconia I should say, is 7 to 9 times harder than titanium. And there's still going to be some movement. And what's going to happen over time is to those screws, to those abutments, right? The other thing is, a lot of times that multi-unit abutment is slightly subgingival, the shoulder, which is where you really want it to be. But sometimes it's a little deeper, and that means that zirconia has, the base of the zirconia, the intaglio that touches the tissues, and then it has that cuff, that thin cuff of zirconia that comes up. That's easily breakable. That's not really greatly supported. So the disadvantage of tie bases is that they can debond, that there's a cement layer. But if you understand, there's different ways and there's different tie bases that you can use to negate a lot of those problems, then you should be using a tie base on these, in my opinion. Or a titanium bar is fine, right? But going straight to zirconia, I think it can be challenging for that connection. And that's something that I've seen very recently. There was an office nearby that went out of business that did a lot of all-on-4 stuff, and we're getting some cases back, unfortunately. And I take the teeth out and you see that cracked zirconia, and it's like, that might be a problem that we see that we have to fix up. The other thing I see is talking about the aesthetics, because, we're seeing a lot of printed, and I'm doing some printed temporaries, and they have kind of like that fingerprint effect on them, those little layers of the printed bonding layers.
Yeah, I know what you
And
mean.
that's that's something that you have to kind of go away. Like I said, the original hybrid with a titanium bar or with a gold bar, even with the denture teeth, it's very aesthetic in my opinion.
Yeah.
I think we're getting away from that a little bit. The interesting thing is patients don't perceive that. You know, most patients want white teeth. They
But
want,
they know it's an interim though. Also.
what's
You're
that?
talking about the interim still?
That's for the interim,
Yeah,
yeah. For
yeah.
the interim.
But the
But
good
they
thing
want a
is like
block
if
of
it
white
breaks, you
teeth.
can just reprint another one and you don't have to like waste your whole half day.
That's an advantage, yeah, absolutely. That's a big advantage to have that. And that's fine, you know, that's one, and we've been doing that as well. We do printed dentures and convert them. We do printed interims. It's an easy way to do a try-in. If you're going to make some changes, you can do a quick, well, I don't like this or this. Okay, we're going to lengthen the teeth a little bit. We're going to do this, right? Or if a patient's having some challenges with phonetics, with the S sound, we can make some changes very easily on the software and then try it out.
That's awesome. That's awesome. But yeah, I really want to thank you for coming out, man. This is like, we could go on and on about this. And for the people that are listening and you want to get into full arch or you have a lot of questions on your own cases, feel free to, message and we'll try to answer all the questions as we go. I may have to turf some of those to Alfonso though, but we'll hopefully get back to you guys on those too. Thanks, man. I really appreciate it.
Yeah, it's my pleasure.
All right.
Thank you.
You're welcome.